Last week, obviously, no classes because of the storm. So Jamie should have emailed everybody, and that lecture for last week would have been last semester's lecture for chapters 5 and 6 that you could listen to. So this week we'll pick up on week 4. So we will cover chapters 7 and 8. You'll see that next week we have 3 chapters, 9, 10, and 12. So next week will be a real busy week. But the week after is Thanksgiving. So we do not have any classes the week of Thanksgiving. So that will give you that extra week, having 3 chapters to get caught up and finish stuff if you have things to do. Excuse me. So what we're going to do again is chapter 7 is the chapter specific guidelines for ICD-10, and then chapter 8 is the introduction to CPT. So we'll finish off the diagnosis coding side of it, and then we'll start with the CPT side of it. Did everybody get their CPT books?
Yes, I got mine.
I haven't gotten it yet. I'm borrowed one.
You borrowed one?
Yes.
And do you have yours, Jean?
I don't have mine with me.
Okay.
I have it.
Okay, you've got it. So when we do the CPT chapter tonight, if I reference pages, just write the page numbers down in your book, and then you can go back and look at that.
Okay.
I forgot what I was going to say. Just because we're going from ICD-10 to CPT does not mean that you're going to stop using diagnosis codes. You'll see that from now till the end of the class, not all questions will ask for both a procedure code and a diagnosis code, but a lot of them will, just so that you keep using the skills from the diagnosis to look them up. So don't think that you won't see them anymore. You will, just periodically throughout. So starting with chapter 7, which are the chapter-specific guidelines for chapters 15 through 21 in the ICD-10 book, which is the pregnancy, perinatal conditions, congenital malformations, chromosome abnormalities, signs, symptoms, abnormal clinical and lab findings, injury, poisoning, and external causes. So if you look on 159, again, chapter 15, the pregnancy, is a difficult chapter for reporting diagnoses, and that's because pregnancy and childbirth is a natural function. So a lot of physicians don't document certain diagnosis codes that should be reported because they figure it's part of the process. Another reason the coding is complex in this chapter is the use of multiple coding in chapter 15. So again, reading the descriptions thoroughly and carefully is again half the battle, and you'll hear me say that so many times I'm sure you will be sick of it. Any condition occurring during pregnancy, childbirth, or the puerperium period is considered to be a complication unless the attending physician specifically documents that it neither affects the pregnancy nor is affected by the pregnancy. If you look at that guideline right underneath there, pre-existing conditions versus conditions due to pregnancy. Again, that's up to the physician to let us know whether or not those conditions that the patient is being seen for are pre-existing or related to the pregnancy so that we can select the correct code. The categories that do not distinguish between pre-existing and pregnancy can be used for either. But the more specific they can be for us, the easier it's going to be for us to select those codes. One important rule with Chapter 15 codes is they are never used on the newborn records. They are only used on the mom's records. So never on the newborns. And I will give you a clue that when you sit for the exam, there's several different versions of the exam, and the reason they do that is because they don't want you copying off the person next to you, because you don't know if they have the same version exam that you do. So they just made all different versions. But one of the questions that I've seen a lot on the exams is they will have a diagnosis of something from Chapter 15. And one of the questions will ask about the newborn. And they're looking to see if you remember that guideline, you cannot use Chapter 15 codes on the newborn's records. So sometimes it's just something that is that simple. Okay, I'll take care of that later. On page 170, first listed diagnosis in a normal pregnancy. Routine outpatient prenatal visits are reported with category Z34, which is encounter for normal pregnancy, and that would be listed as the first diagnosis. If there is a complication, then you would code the complication, not the Z34 routine pregnancy. One thing that I'll mention in the chapter is Chapter 15 codes also take sequencing priority. So if you were coding a pregnant mom and she had tonsillitis, the code that's going to appear first is the code from the Chapter 15, and then the tonsillitis would be reported after. But if there are two conditions and one comes from Chapter 15 and one comes from, let's say, the skin section, your Chapter 15 codes will always come first. They are sequenced first. First listed diagnosis for high-risk patients. Some patients are considered high risk for complication during pregnancy. When these encounters occur, we are going to have a code from category O09, supervision of high-risk pregnancy. So again, telling us that that one would be coded first. The first listed diagnosis for delivery. Episodes when no delivery occurs. So if the patient goes in labor, but no delivery, we use the principal diagnosis according to the complication which necessitated the encounter. When a delivery occurs, the principal diagnosis should correspond to the circumstances or complication of the delivery. And if it's a C-section, it would be according to the C-section delivery instead of a vaginal delivery. And outcome of delivery. A code from Z37, outcome of delivery, should be included on every maternal record when a delivery happens. You only use it once. So if the mom delivered at 8 o'clock tonight, they would use that Z37, but then when the doctor goes in tomorrow to see the mom, it would just be a regular postpartum visit. The outcome of delivery would not need to be used on tomorrow's visit. And again, the outcome of delivery is only on the mom's records. You will note that pregnancy is broken up by trimesters. So the final character in your codes in the pregnancy section will designate the trimester of pregnancy. So if you look on page 172, the first trimester is less than 14 weeks. So it would be from day 0, less than 14 weeks, 0 days from the last menstrual period, Second trimester would be 14 weeks, 0 days to 28 weeks, 0 days from the last menstrual period. And the third trimester would be 28 weeks until you deliver. The selection of trimester for inpatient admission can encompass more than one trimester. So there is times that the mom might be admitted for a longer period of time with like hyperemesis, excessive vomiting, and that could be throughout her first trimester going into her second trimester, for example. So sometimes on an inpatient, there may be an overlap of trimesters that will be covered. We do have a code for unspecified trimester. Hopefully, your physician knows what trimester their patient is in, but let's say you have somebody from out of state visiting, or nowadays we see a lot more people having babies that didn't even know that they were pregnant. So they have no idea how far along they are. If that is the case, they would use an unspecified trimester. There are times when the first listed diagnosis on 172 for a pregnant female will not be a code from Chapter 15. So if the physician documents that the pregnancy is incidental to the encounter, there is a Z33.1. If the encounter for a complication to which no delivery occurs, the complication is going to be the first listed diagnosis. There are conditions due to pregnancy, and those same conditions that may have been present prior to pregnancy, such as high blood pressure. On 173, postpartum and peripartum periods. So a peripartum is your last month of pregnancy to 5 months postpartum, and postpartum is immediately after delivery to 6 weeks after delivery. If your patient has pregnancy-related complications after the peripartum and postpartum period, they have to document that the condition is pregnancy-related in order to continue to use codes from this Chapter 15 section. Excuse me. If the mother delivers outside the hospital, then there is a diagnosis code Z39.0, which says this is an exam after immediate delivery. So this would be in the instance that they deliver in their vehicle or in an ambulance, and once they get to the hospital, that would be the diagnosis code that they use. They did not deliver the baby, so they can't use the other codes. If it is a normal delivery, 080 or 080, would be reported as the first listed diagnosis for a full-term, uncomplicated delivery of a single healthy infant without any complications. Again, if they have complications, but that complication is not present at delivery, it's still the 080, because that complication occurred maybe 4 weeks ago, but it was not at the time that the delivery occurred. The outcome of delivery, 080, is reported with a single live birth, so that's Z37.0. And again, remember that Z37.0 is only used on the mom's record once. On the bottom of 174, ectopic pregnancy. This is where the eggs fertilize outside the uterus. These would be reported with codes from 000, and those codes are based on where that pregnancy occurred. So if it got fertilized and implanted in the ovary or in the tube, and then with or without intrauterine pregnancy. There are also codes for complications that go along with ectopic pregnancy, and those are 080. We have, if you look at the bottom of page 174, hydatiform mole. This is a tumor of the placenta, and it does secrete hormones, chorionic gonadotrophic or CGH. It's reported with a code from 001. If it is a malignant, it would be D39.2. So here again, your physician has to let us know. We would not have any way of knowing whether it was malignant or not. If you look on 175, that is what a hyatiform mole would look like. Hypertension in pregnancy. So when hypertension is a pre-existing condition complicating pregnancy, delivery, or that 5-month period after delivery, we are going to report the hypertension with a code from 010. Pre-existing hypertension complicating pregnancy, childbirth, and puerperium. The see, I get those mixed up all the time. Now I know why they did it. The 010 code would be listed first, and then you can use the secondary code if there's any hypertensive heart disease or hypertensive kidney issues or anything like that. But again, when hypertension is pre-existing, 010. And that again would be the first listed code. On page 176, and if you haven't figured out already, in the box is the actual guideline, and then it summarizes underneath that. So what you see in the orange box is going to be what the guideline actually looks like in your ICD-10 book. I'm kind of summarizing from the middle.
I have a question.
Yeah.
Oh, sorry. For pre-existing for hypertension, does that mean pre-existing prior to pregnancy or prior to birth, giving birth?
Prior to birth. So if it was during the pregnancy period. Yep.
Okay.
Yep. What you'll find is a lot of them will not have hypertension until they get pregnant. And then because of all the changes going on at some point during the pregnancy, that's when they note that the blood pressure starts to be elevated. And then that would be when that code would be used.
Yeah, I had that. So I was wondering if it was, okay.
Yeah, because then, remember with hypertension, most of the people, once you get it, if you're not pregnant, it kind of sticks with you a long time because most of the time you can't get rid of it yourself. But with pregnancy, that's a different situation. Usually the hypertension is caused by the pregnancy, and once you deliver, normally the hypertension goes away, so you're not labeled with that hypertension unless it continues after that 5-month postpartum period. Then you may get regular hypertension, but during that time period.
Okay, thank you.
You're welcome. So the fetal conditions 035 and 036 report fetal abnormalities affecting the care of the mother. So again, it has to affect the care of the mother. If abnormality or problem is present but doesn't affect the care of the mother, then those are not reported. It has to affect the mom. Diabetes in pregnancy. This can lead to severe complications for mother and fetus if it is not controlled during pregnancy. So type 1 diabetes, there is little or no insulin being produced. So it can be controlled with insulin, and it may be reported with long-term use of insulin, depending on how long you have to take the insulin. Type 2 diabetes, there is too little or the body cannot use the insulin that is being produced. This can be controlled with diet, medication, and or insulin, and may also report long-term use of insulin. So type 1 and type 2. If the pregnant female has type 2, that is well controlled with medication, it would be a code from 024. This would be the first listed diagnosis code, followed by a code to report the diabetes, E11.9, which is type 2 without complications. And if they're being controlled with insulin, there is a Z79.4, which is a long-term use of insulin that you could use in addition. Gestational diabetes develops in your second or third trimester in a patient who typically did not have diabetes prior to pregnancy. This would be, depending on the severity, would be reported with a code from 024. Again, diabetes in pregnancy, childbirth, and puerperium. And then again, if they are using long-term insulin, you would not report that with gestational diabetes, because if it is classified as gestational, it's only occurring while you are pregnant. So they do not want to label you with that long-term insulin use when you're pregnant, because it will go away once you deliver. So again, if it's gestational diabetic, do not use the long-term insulin. So look on page 178, and let's look up number 3. False labor, 38 weeks undelivered. False labor, 38 weeks undelivered. Where do you think you're going to start there?
Labor.
Labor? Okay, let's try it.
Says C delivery.
See delivery. Okay, so let's go to delivery instead. Delivery.
Oh wow.
Oh, brother. Holy cow. All right, let's see if there's a
False.
I don't see any faults.
Yeah.
Let's see. Delivery complicated by.
I looked under failed.
Under failed?
Yeah. That. Nope.
Okay, so we looked under delivery, right?
Mhm.
That didn't work. Did anybody try labor?
Yeah, we tried labor and then went to delivery, right?
Yeah.
Labor
Maybe-
says use delivery. Okay, we didn't find anything under delivery.
I
What
tried
about
pregnancy.
How about undelivered? Under.
I looked under fault.
Did you
I'm going
find
to go
it
under pregnancy.
faults? Or
Yes.
pregnant? Okay,
Under pregnancy.
under pregnancy?
Yeah, it says false labor or after 37 completed weeks of pregnancy.
Okay, so that one is one that you can find under P for pregnancy and then faults, or under the word faults. So where does it lead you?
It says to go to 047, excuse me, .1.
047.1? Okay, let's
Yeah.
go check that out. 047.1. Oh. False labor.
At or after 37 completed weeks of gestation.
Yep, 047.1. That is correct. Now, I have a question. What happens to that says that it's a false labor. But we also, and this book, it should have said codes. But what it wants you to also do is go to the actual Z codes for when the trimester that they were pregnant in. Even though that one says false labor at or after 37 completed weeks, what it also wanted or would like you to do is to go and actually code the encounter for the pregnancy. And if you go to, I think it's the word encounter. Let me see if it leads you the right place. That one code is enough for the claims, but for completeness sake, they want us to throw in the encounter for, and let's see if they have pregnancy. If I could spell.
Yeah, they have encounter for pregnancy.
And it
On
says
page-
pregnancy supervision.
Mm-hmm.
All right, so let's go to pregnancy supervision. Pregnancy supervision. Holy Moses. Supervision. Holy Moses. On page 1433, the middle, bottom, and top right column, we said she was 38 weeks. Toward the end of the pregnancy section. Does anybody have what it led you to?
Z38.38.
Z3A.38, correct. And when you look at that in your book, all it says is 38 weeks gestation of pregnancy. So that's just adding a more specific gestation, because that first code said 37 weeks or. So this is just giving a little bit more specific information. So that one would have two codes, O47.1 and Z3A.38. Does that make sense?
Mm-hmm.
And what I did is I made a note in my book, in the alphabetical index. What I did is kind of highlighted those gestational weeks, and I put add to false labor codes. So that way, that was a good way for me to remember to add those codes. Certain conditions originating in the perinatal period. So these are from chapter 16. So these are the newborn guidelines, the codes for perinatal period, before birth through 28 days. So codes from chapter 16 are only for the newborn record. So 15 for the mom, 16 for the baby. These codes, again, never reported on the moms. These codes are not for congenital malformations, deformity, or chromosome abnormalities. And again, that's not something you need to memorize. If you were going to look up something related to a chromosome abnormality, it's going to lead you to codes in the Q section. So with perinatal period, what do we use as the first listed diagnosis? So the first listed diagnosis on the newborn record would be a code from the Z38 section, live born, and it would be according to place of birth and type of delivery. So this would be the first listed code on the initial record of the newborn. Again, only on the initial birth record, not the mom's record and not the subsequent daily visits or however many visits the baby might get. Congenital malformations, deformations, and chromosome abnormalities. Chapter 17. These are codes Q00 to Q99. These are congenital anomalies and conditions originating in the perinatal period. And remember, the perinatal period extends 28 days following birth. This only applies to the baby. Postpartum applies to the mom. So perinatal, newborn, postpartum, mom. Codes from 17 can be assigned beyond the perinatal period, but the condition had to have originated during the perinatal period. So again, here's where we rely on our physician's documentation. If it's documented that it occurred during the perinatal period, then we can continue to use that diagnosis beyond that time period. On to page 180, and on 180 is what we just went over, the malformations. On 181, an anomaly is an abnormality of an organ. Congenital means it is something one is born with. So some anomalies are noticeable and discovered at birth. Sometimes it can take months or years before that anomaly is diagnosed. If there's a question as to whether it's acquired or congenital, again, we either reference the record or ask your physician. The physician needs to document that abnormality, and it can be either the first listed diagnosis code or it can be used as an additional code. If a patient is admitted for the purpose of birthing, report a code from Z38, which is the live born infant. That would be sequenced as the first code. And then if there are any other congenital or anomalies, those would be listed in addition. There's one that's pretty popular, the trisomy 21, which is the Down syndrome. And that's due to a cell having two 21st chromosomes instead of one. Some cases are due to mosaicism. Others have the trisomy 21. Usually this is something that's noticed when the baby is born. Sometimes it may not be able to be picked up right away. If it's cellular mosaicism, there is a mixture of various cells of the same type. And if it's tissue, one set of cells has normal cells and the other has the trisomy 21. There is a abnormality called Robertsonian translocation, where there are irregularities in the 21st and the 14th chromosome. And again, nothing you need to remember, it's just these are different abnormalities that you may see that you have to code. All of the codes in 17 report chromosomal abnormalities, such as Fragile X, Klinefelter syndrome, the mosaicism, the Down syndrome, for example. The physician needs to document the type of chromosome abnormality in order for you to bill it properly, to code it properly. And if he's not giving you enough information, then what I recommend you do with any code is go to that section of your ICD-9 book, pull up those Q codes, photocopy that page if you need to, and say, look, I need more specifics in order. I need to know what type of abnormality it was. So look down at the exercise 7.2 and look at number 3. We have a 3-year-old with Fragile X syndrome. Where are you going to start there? Fragile X syndrome.
Syndrome?
Syndrome? Let's try it. Anybody else want to try the other word? lots of syndromes. If you went to
Q99, oh,
yep,
Q99.2.
Q99.2. And this one, if you went to syndrome and then Fragile X, if you went to fragile, you would have found it under Fragile X as well. And if you went to that code, it is correct, Q99.2. And it reads, bear with me here, Q99.2 says Fragile X chromosome or Fragile X syndrome. That's all it says. Pretty straightforward. Okay, we talked about signs, symptoms, and abnormal findings. This is chapter 18. So signs and symptoms are assigned for encounters if there is no definitive diagnosis date. So a sign is an objective evidence of disease observed by the physician, and a symptom is a subjective observation reported by the patient but not confirmed by the physician. So we can use codes from chapter 18 when we do not have a more specific diagnosis, when signs and symptoms exist at the initial encounter and they prove to be transient, and again, we do not have a cause for those symptoms. The patient fails to return, so we can't follow up, we don't know what's causing it. A case, maybe you refer them elsewhere, a more precise diagnosis not available, and certain symptoms that represent important problems in the medical care exist, and it may be desirable to classify them elsewhere. So again, it is okay to use signs and symptoms as long as we do not have a definitive diagnosis. So again, go back to that patient that presents with abdominal pain. That doctor sees them, can't come up with a reason for the belly pain, but we order a ultrasound on them and we tell them to come back in a week. That day, all we got to go on is the belly pain. When they come back in a week and we go over their ultrasound results, maybe he finds out that the patient has an ovarian cyst. So now we know a reason for that abdominal pain. That follow-up visit now becomes ovarian cyst. We do not have to use the pain anymore. We have a definitive reason. So again, we can use symptom codes, combination codes that include symptoms. So some of those we may come across. There are combination codes. If you look on 183, look at D. There is a code for repeated falls, R29.6. There's also a Z code for history of falling. They can be assigned together. It's going to be dependent on how your physician documents it. Unfortunately, we use these a lot in orthopedics because we have an elderly population that falls and breaks things. So depending on how the physician codes it, sometimes it's going to be the repeated falls and other times it's the history. Excuse me just one second. My son's calling from Wyoming. I just got to tell him I have class. ABB? I have class, so can I call you back later? Okay, I'll try you back later, okay? All right, thank you. Bye. Sorry about that. Just have to make sure he doesn't need anything dire emergency. On 184, there's codes for coma scales in the symptoms, signs, and abnormal clinical findings. So the coma scale codes R40.2 can be used in conjunction with traumatic brain injury codes, cerebrovascular disease, or sequelae cerebrovascular disease. These are typically used by trauma registries, so typically they're more or less used in the emergency room setting when people present there. It's probably not something you're going to see in your office, but be aware of the codes for the coma scale. R53.2 is a functional quadriplegia. So that is the lack of ability to use one's limbs and to ambulate due to extreme debility. It is not associated with neurologic deficit or injury. That code R53.2 should not be used for cases of neurologic quadriplegia. It is just a functional. So again, here your doctor may not tell you whether it's functional or neurological. And in order to select the appropriate code, you may need to find out which one it is. There's also a code for SIRS, Systemic Inflammatory Response Syndrome, R65.11. R99, death, not otherwise specified. This would be in the case of somebody who already died and they're brought into the emergency room. Pretty much, we have no other information, no reason for the death. So at that time, it can be coded as a death not otherwise specified. And then we have the stroke scale, R29.1. And these are used in addition to acute stroke codes in the I section. So again, if you are working for a physician that deals with these types of codes, you just want to be aware that you are going to have the stroke scale, and then you're going to have the acute stroke codes as well. So you would have two codes in those situations. You do not report codes from Chapter 18 when a definitive diagnosis is available. And again, we've said that before. As far as the abnormal clinical and lab findings, that typically is going to be the word you go to. One method to find abnormal findings is to look under the word abnormal. When reporting complications of surgery or medical care, we have to make sure that that complication is documented. And what a surgical complication is one taking place as a result of the procedure. Just because a complication occurs following a procedure doesn't mean it's a result of the surgery. So don't assume that cause and effect. We need to ask our physician to make sure it is truly a complication of surgery. So the term complication as used in ICD-10 does not imply that improper or inadequate care is responsible for the problem. No time limit for the development of a complication. So again, when we are coding these, we want to follow all instructional notes when locating complication codes. So again, here's probably where you're going to see, Jeannie, a lot of the excludes 1 and excludes 2 with the complication codes. Look at 7.3 and look at number 3, abnormal mammogram. We don't know what's abnormal about the mammogram. We just know it's abnormal. Where are you going to look?
Abnormal.
Abnormal. Let's do it.
R92.8.
R92.8. That is correct. And if you went to R92.8, it reads other abnormal and inconclusive findings on diagnostic imaging of a breast. So we don't know that it's breast cancer. We don't know that it's a cyst. It's just abnormal. Something didn't look right. So until they know what it is, it's abnormal. Correct. R92.8. And if you went to the word mammogram, all you find under mammogram is routine. So at that point, I would say, okay, I have to go try to find another word because that obviously doesn't fit the abnormal. On page 186, injury, poisoning, and certain other consequences of external causes. You can see here, if you look down below, these codes start S00 to T88. Injuries to the majority of the body parts here. Burns, frostbite, poisoning, complications of surgery, effects of foreign body entering through natural orifice, and again, injuries to several different body parts. A lot of injury codes have that seventh character, and that seventh character, if you look in the middle of that orange box, we have A for initial encounter, and this is used for each encounter where the patient is receiving active treatment. The seventh character D, subsequent, is used for encounters after the patient has completed active treatment of the condition and is receiving routine care during the healing and recovery phase. And then we have the seventh character of S for sequelae, used for complications or conditions arising as a direct result of that condition. So this would be, for example, a scar after a burn. That would be an example of when we would use the sequelae, or the S. So A, D, and S are typical 7th-digit characters for your injuries. If you look on 188, coding of injuries, you want to code each injury separate unless there is a combination code, which is one code that would describe both injuries. Unspecified multiple injuries should not be assigned in the inpatient setting unless information for a more specific code is available. So typically in the inpatient setting, they're going to have to be specific. They're not unspecified. Traumatic injury codes are not to be used for normal healing surgery wounds. Well, that should make sense because if it's a traumatic injury, it's not normal and healing. The traumatic part would be maybe one of the first times that you would see them. Superficial injuries such as abrasion or contusions are not coded with more severe injuries of the same site. So we see a lot of people, motor vehicle accidents, and they have, let's say, broken bones, and where, road rash, let's say. So they broke their radius, but they also have abrasion and, all that mess on their arm. We're not going to code the abrasion because that's part of the fracture, unfortunately. So superficial injuries you would not code. Primary injury with damage to nerve or blood vessels. The primary injury would be sequenced first with additional codes for the injury to the nerves or spinal cord. With the multiple injuries, the physician needs to indicate the most serious condition. That would be the first listed. Then again, you can list anything in addition to that, but we want to know what the most serious one is. That's the one that would be sequenced first. When we talk about burns, we code the 3rd-degree burns first rather than the 1st-degree burns if they were to have both, because the 3rd-degree burns are much more severe. So the same thing here. Multiple injuries, the one that is most severe first. If you look up at the top of page 189, fractures. If a fracture is not indicated as open or closed, we code it as closed. Now, an open fracture is one you can see, which means the bone has broken through the skin. So if your doctor doesn't specify, we can only assume it's closed because that is the least invasive. If a fracture is not indicated as displaced, or not displaced, we code it as displaced. And again, any doubt, ask your provider. If there's a dislocation and a fracture of the same bone, we report only the fracture. That is the most severe. The dislocation would be considered part of the process, so to speak. So, how do we code fractures? Again, fractures are specified to site. So, depending on the body part, again, if it's not stated as open or closed, we code it to closed. If it's not indicated as displaced or not displaced, it is displaced, or we code it as displaced. If you look down in the middle here, initial versus subsequent encounters for fractures, again, that's that 7th digit, so A, B, or S for sequelae. So again, go back to that. A is if it is an encounter where the patient is receiving active treatment. D would be they have completed active treatment and they're in the healing phases. And then S for sequelae is complications or conditions arising as a result of that injury. So again, be aware of your 7th digit. Some of your 7th digits for fractures are also A for closed, B for open, D for a subsequent with routine healing, G subsequent delayed healing, K subsequent non-union, and the S again for the sequelae. We can't determine if it's healing routinely or if it's delayed. Again, we're going to rely on our physician. So if they're not giving you that information, you can't code that fracture without that 7th digit. So which means we need to ask, because I'm not going to guess if it's routine or non-union, because if I went with routine and it was a non-union and they take them to surgery next week, the insurance company may question why they're going to surgery if last week we said the fracture was routinely healing. That was my error. I should have had non-union. So that can make a little difference on some of your claims being processed. Multiple fractures, again, you sequence according to severity. If it is, again, a dislocation and a fracture of the same bone, we code only the fracture. If you look on page 190, you will note in the middle there, we have something called a pathological fracture. So there's going to be a regular fracture and a pathological fracture. Pathological fracture is also by body part, but if it is a pathological fracture, it's one that occurs due to a disease or weakening of an area, such as osteoporosis or something along that line. So, traumatic fracture versus pathological. Our physician, needs to let us know. Because an ankle fracture on a woman who's, let's say, 86 years old, let's say she was walking and she tripped and rolled her ankle, but she broke it. Yes, to me, that sounds like a traumatic fracture. But if that 86-year-old has a history of osteoporosis, it is possible that that's a pathological fracture. Because if she didn't have osteoporosis, she may not have actually broken that bone. So again, be aware of the difference between pathological and traumatic. Again, multiple fractures sequence in the order of severity, with obviously the most severe sequence first, and if your provider doesn't give you that information, we need to ask. When there is aftercare encounter for fracture, such as cast removal, removal of fixation devices, stitches, anything like that, there is a Z code for encounter for orthopedic aftercare. And that is what we use. And the seventh character would be D to indicate subsequent encounter with routine healing. So if you look on 191, here's the fracture of the femur, so S72, and there's all your A through S that can be assigned as your seventh digit. So do you see what I mean, where if your physician just tells you it's a fracture of the femur, we're not going to be able to code it. We need to know initial, subsequent, non-union, malunion. So what I've done is I've made copies of these little boxes and I've taped them on my provider's wall. That way when they're coding, they look and they remember that I need that information if I'm going to code it properly. And if I can't code it, then that claim's denied getting out. So by doing that, it actually, they thanked me, and it makes their life a little bit easier as well, because there's no way they're going to remember what letter stands for what, because it can differ from code to code. So this helps them do that. And again, you'll see your exclude 1 and exclude 2, so you'll see these with your fractures as well. Chapter 19, injury, poisoning, and other consequences of external causes, so burns and corrosions. So we need to distinguish between burns and corrosion. So burns are injuries resulting from a heat source, not sunburn. Sunburn is not considered a thermal burn. A burner on a stove, hot water, that's a thermal burn. Electrical and radiation burns are also considered burns. Corrosion burns are due to chemicals, but the guidelines are the same for burns and corrosions. Okay? Burns are reported based on degree of the burn, so first, second, or third, except if the burn is in the eye or an internal organ. Then it is coded by site. Again, you're not going to need to remember that when you went to look up burn of the eye. It's going to lead you where you need to go. So burns, first, second, and third degree. They're classified by depth. So your first degree is erythema or redness. Second degree is blistering and epidermal loss, so that loss of that first layer of skin. Third is full thickness, so deep necrosis of underlying tissue or full thickness skin loss. Again, sequence highest degree of burn first. So if you have a third degree burn of the hand and a second degree of the chest wall, third degree goes first, and then your second degree for the chest wall. If there are different degrees of burns at the same site, so let's say on that chest wall, you had a third degree burn up in the right corner, and then you had a second degree burn more towards the middle. If it's in the same body, organ, or area, you only code the highest burn. So all you would need would be the third degree. So again, sequence first, highest degree of burn, multiple burns, same area, only report the highest degree burn. If we have an infected burn, you're going to use additional codes for the infection. And there are also going to be instances, if you look in the guidelines, number 8, sequelae, when appropriate, both a code for current burn or corrosion with a 7th character A or D, and a burn with the S for sequelae may be assigned at the same time. Burns and corrosions do not heal at the same rate, and a current healing wound may still exist with the sequelae of a healing burn, or a healed burn, excuse me. So it is possible to have both an A and a D, and then a code with an S as well. Look on page 194 and look at number 2. So we have an infected 3rd-degree burn, left thigh. It covers 4.5%, and it's a subsequent early treatment. So it's breaking it down for you, which is nice because when you're learning, I think that helps kind of program your brain. So let's find that code for the 3rd-degree burn of the left thigh. 3rd-degree burn, left thigh. Where are you going to start there? What word do you think?
Burn.
Burn, okay. Okay.
T24.312.
T24.312. Okay, so you went to thigh, and then we know it's the left thigh, and then 3rd degree. So T24.312. So let's go T24.312. And on page 899, 24, no, see? Nope, scrap that thought. I didn't go far enough. 24, not 23. 24312, page 903. Burn, 3rd degree, left thigh. All right, so we got that one. It requires the 7th digit though, so what's the 7th digit? Look back under the base code of T24. You've got A, D, or S. Those are your choices for this code.
D, right?
D, correct. Subsequent early treatment. So it's a subsequent encounter, correct. So now where do you think you're going to look for the infected burn code? What word do you think you're going to start with there?
Still burn.
Burn, okay.
No.
Nope. Anybody try anything different? What about infection?
Yeah.
I don't see that. Not under infection. Is that what you said?
Yep. There's nothing under infection.
Yeah, I don't see burn under infection.
No, I don't see burn.
All right. Let's see. I'm trying to think what else it might be. Infection. Okay, so this is a little bit tricky, and this is why I like to pick some of these. There's not anything that says specific infection related to the burn, but right after the word infection, infected, or infective, there is a code B99.9. Look on page 1336. where the actual infection category starts.
Yep.
That's a non-specific infection because we don't know anything else about it. And yes, you're correct in that there's not one that specifically says anything related to burn. So if you went to that code and read it, it just says unspecified infection disease. So that is what that is. It's an unspecified infection. We don't know anything else about it. But now the extent code is the percentage of the body that was affected. So where do you think you would go to find that percentage code?
Back to burn.
Back to burn, okay? And when you get back to burn, then what are you going to look under?
Phi.
Under percents.
Percent or what's the
Extent
key
of-
word? Extent.
Oh, yeah.
Page 1169.
T31.10.
Okay, so where did you go to get that?
Extent, and then it just says percentage of body surface.
Okay,
Oh,
less
so
than
less than 10.
10%.
Yeah, T31.0.
T31.0, correct, because it's less than 10%. So this one, you have to be careful because you look and when you get to 10 to 19%, that breaks down even more to give you what percentage of that 10 to 19% was third, category 3 burns. So yes, so this one we've got the 3rd degree burn, then we've got the infection, the B99.9, then we've got the percentage, the T31.0. And again, me not coding burns, if this was something I was going to code all the time, then obviously having that extent or that percentage is something I would know I'd have to throw in every time. But if it's something that helps you as you learn in the burn by the codes or whatever, you can put code also extent so that you're, maybe it's reminding you somehow to make sure you're coding that percentage. And again, sometimes your physicians maybe aren't going to give you that percentage, and we have to say, look, we need it if we're going to code it correctly. Coding adverse effects. Again, we went through the burns. Now we're going to go through the poisoning, underdosing, and toxic effects. So in this one, we are not going to code directly from the table of drugs. Always refer back to the tabular list. And if you recall in your ICD-10 book, your table of drugs, if you have this gray one that we have now, your table of drugs start on page 1543. So if you want to tab it so you have easy access. But again, just because you're finding that drug here, you want to go read the description in the numeric to make sure that it is what we are looking for. Use as many codes as necessary to describe all drugs, medicinal or biological substances. If the same code would describe the causative agent for more than one adverse reaction, assign the code only once. So don't repeat the code. If 2 or more drugs, medicinals or biological substances are reported, code each individually unless there's a combination code that includes those 2 medications. Otherwise, you want to look for a code for both individual medications. When you are coding an adverse effect of a drug that has been correctly prescribed and properly administered, Assign the appropriate code for the adverse effect, followed by the appropriate code for the adverse effect of the drug, T36 to T50. The code for the drug should have a 5th or 6th character. So again, T36OX5, for example. Poisoning, so you'll see up at the top of your table of drugs and chemicals, you've got poisoning accidental, poisoning intentional, poisoning assault, poisoning undetermined, adverse effect, and underdosing. So this is helping us determine which column we are going to pick that from. When coding a poisoning or reaction to an improper use of medication, so an overdose, wrong substance, wrong route of administration, you first assign the appropriate code from category T36 to T50. The poisoning codes have an associated intent as their 5th or 6th character. If we do not know the intent of the poisoning, if we know it to be unknown or unspecified, we code it as accidental. The undetermined intent is only for use if documentation in the record specifies that it cannot be determined. So again, unless you train your physicians for what type of information you need when you're coding overdoses, you're going to need to probably query them because they're not going to know what they need to document for you. With the poisonings, if there is a diagnosis or of abuse or dependence of a drug, that can be assigned as an additional code. Error made in a drug prescription, for example, an overdose of a drug intentionally taken, that would be coded as a poisoning. If you look on 196, non-prescribed drug taken with correctly prescribed drug. If this was taken in combination, any drug toxicity or reaction resulting from those drugs is considered a poisoning. If you interact a drug and alcohol, that is classified as a poisoning. Underdosing is taking less medicine than prescribed, which is pretty straightforward. Underdosing should never be assigned as principal or first listed. So if it's an underdosing, we need to find another code that's going to go before it. A lot of times you may see it as a non-compliance code, Z91.12 to Z91.13, or complication of care. And toxic effects, harmful substance ingested or comes in contact with a person, that is a toxic effect. Toxic effects have an associated intent, accidental, self-harm, assault, and undetermined. So again, picking the correct column, that's why we go back and read it numerically after, because we may look quick and think it's accidental, unintentional, but when you go read that description, it may not fit what you're looking for, so we want to pick a different column. So you can see down below, T36.0x1A is unintentional poisoning. OX2A is intentional. So everything else is the same, but that one digit. Again, there are often multiple codes to completely describe the substances involved. So again, we want to be careful when we are using those. Adverse effect occurs when a substance is taken correctly, but the patient has a negative reaction to that substance. So they give you amoxicillin for a patient with bronchitis. They take it and the medication causes a rash. The rash is considered an adverse effect. Again, poisoning occurs when medication is incorrectly taken. And again, down below, excuse me, the code in the first column, poisoning, accidental, unintentional, is for a substance involved but not related to an adverse effect. Second column, poisoning, unintentional self-harm, when the external cause is a result of a person intentionally taking the substance. Third column, poisoning assault, intentional infliction by another person. Fourth column, poisoning undetermined, the intent not known. Adverse effect, we just talked about. And underdosing, taking less of the medicine than was prescribed. So look down at the bottom of 197 and look at number 2. Accidental poisoning by herbicides, subsequent encounter. So what are you going to look for in your table of drugs and chemicals?
Valium.
We're doing number 2.
Oh.
Accidental poisoning by herbicides, subsequent encounter.
Herbicides.
Herbicides, let's see if we find it. Did you all find herbicide in the table?
Yep.
And what column are you going to take it from?
Poisoning accidental.
Accidental, so the first one. So what did that give you?
T60.3x1.
Okay, T60.3x1. Now you'll see in the table of drugs and chemicals, again, part of the reason we go to the numeric is because it doesn't give us our extra digits. So let's go look at that T60.3x. X1, toxic effect of herbicides and fungicides, accidental, but it's telling us it needs that 7th digit. So you want to go back to the base code, which is T60, and it gives you a choice of the 7th character as A, D, or S.
So it would be D.
It would be D, correct, for subsequent encounter. So T60.3X1D. Yep, correct. So when you're dealing with the poisonings, go and use that table of drugs and chemicals. It's the easiest way to look it up. You can also look it up alphabetically, and it will eventually get you to the numeric. It's just a little bit longer way to do it. On page 198, again, it goes over the columns that we just went over. 199, the abuse, neglect, and maltreatment. The codes in category T74, adult and child abuse, neglect, or other maltreatment confirmed, or T76, suspected, are sequenced first when reporting abuse, neglect, or other maltreatment. And you would also report an external cause code from the X category, X92 to Y08. If the perpetrator is known, we can report Y07. For example, they have husband, they have a few other ones there as well. Report T74, only report T74 when the medical documentation states abuse, neglect, or other maltreatment confirmed. If it is not confirmed, it is suspected. That's just like you're not gonna give somebody AIDS if it's not confirmed. So we have to be careful with that. If abuse, neglect, or maltreatment is suspected and then ruled out during another encounter, there is Z04.71 if it was ruled out for an adult, and Z04.72 for a child. By using that, if it's ruled out, it then takes that diagnosis of the abuse away from that chart so that no further investigation goes anywhere from there, which it could, but on page 200, open wounds, lacerations, and punctures. Open wounds, lacerations, and punctures are separate entries within the index of ICD-10. So again, open wounds you'll find under wound and then open. Lacerations are found under the word laceration, and punctures are found under the word puncture. Look on page 202, complications. When a patient is admitted for a complication resulting from medical care or a surgical procedure, the complication would be listed first. So again, it talks about pain due to medical devices. There's a T code. There's a G code, G89, for acute or chronic pain due to the presence of a device, implant, or graft. Transplant complications other than kidney, and then kidney transplant complications. So when we're coding the complications, again, we need to know what type of complication it is, surgical complication, organ transplant complication. If you look on 203, complication codes including the external cause. So some of your complication codes have the external cause already in that code, so you do not need an additional external cause code. Complications of care codes within the body system chapters. So most of the, like if it's a musculoskeletal complication, those complication codes are probably going to be found within that body chapter, is what that is saying. So complications of care codes within that body system chapter. Again, complications must be documented by the physician. The medical record also needs to document relationship between procedure and complication. If it is not documented as such, then it is not a complication. Again, we cannot assume. If the pain is due to, again, a medical implanted device or graft, that needs to be documented as well, that pain is related to that screw or pin that was put in for that fracture. And again, there's the transplant. A code also reported for the complication resulting. So if that organ is rejected, we're going to use a code for that complication and then one for the organ transplant. Look on page 204 and look at number 1. Initial encounter infected breast implants. Where do you think you're going to start there? Initial encounter infected breast implants.
Infected.
Infected. Okay, anybody else? Anything?
Implants? I don't know if that
Implants?
is-
Okay, let's try. So we got infected, we got implants. I can't spell tonight. Alright, so let's see. Infection.
I don't see it under infected.
Okay,
And I don't think it would be with implant.
Well,
I give you a little hint. What's right after where it says exercise 7-7?
Oh, complication.
Right, the infection is a complication of the implant. So try the word complication instead. See, this is where sometimes we got to do that play with words to find the right one. Look on page 1188.
Yeah, it says breast implant.
yeah.
Complication of breast implant.
T85.9.
Okay, now the breast implant says T85.9. Look down underneath that, though, for the word infection.
Infection and inflammation. T85.79.
So let's take both of those and see what the difference is between the 0.79 and the 0.9. So let's go to T85. So if we went to just the T85.9 first, that just says unspecified complication of internal prosthetic device, implant, and graft. So to me, that right there is not really specific enough because we know it's a breast implant. So now let's look at the 0.79. Infection and inflammatory reaction due to other internal prosthetic device, implant, and graft. And we know it's an infection, right? Because it says infected breast implant. So in this instance, they're going to go with the 79 code instead of the one that says unspecified complication. And that is because of the word infected. So we've got T85.79. It says next to it, X would be the 6th digit, but then we need a 7th digit. So what would be your 7th digit? Or character, excuse me. To find what your 7th digits would be, go back to that base code, that T85.
A?
A for initial encounter, correct. Always remember that your 7th digits are always going to be under the base code, which will be the first 3 digits. They're always going to be listed there for anything under that specific set of code ranges. So T85.79XA. Does that make sense?
Yep.
Okay. Any questions on the guidelines for those particular sections? I think what you will find is the more you start looking up the diagnosis codes, the more the guidelines make sense. And again, if helping you with the guidelines, like for chapter 15, write only in mother's chart. Chapter 16, only in baby's chart, or whatever. Anything like that will help you. Because, again, when you sit for the exam, everything you need to pass is in those 3 coding books that you take with you. And that includes the guidelines. I referred to the guidelines on several occasions, just because I couldn't remember, like when coding AIDS, about being suspected versus confirmed. That's the type of thing you'll want to use your guidelines for. Okay, so now we're going to get into the procedural side of it, which is your CPT. So again, if you don't have the book with you tonight for that, if I do refer to pages, just go ahead and write it in your textbook, and then you can look at them when you get home. So, introduction to CPT. So, CPT, we'll talk about the purpose when it's updated, format, again, how to use it and how to use it is no different than your ICD-10. You always look it up alphabetically first, get the codes, ranges of codes, and then go to what you call your tabular or numeric, look up the code, read the description, and make sure it matches. Again, reading is half the battle, paying attention to the words. Some codes, the difference is the word and, or one body part versus another, or laterality. So we just need to make sure we're reading carefully. And I know I do it. If I'm tired, I'll look and think I saw right, and it wasn't right at all. And that can happen when you're taking the exam, because you're sitting there. I proctored it this weekend, and I had 11 people come. And by the time they hit the 2-hour mark, you could see the fatigue setting in. You could see the panic. And, 5 hours and 40 minutes, the phones have to go away. We do keep a clock in the room, but we don't put it up on the wall because everybody'd be looking at it, and that's worse when you're taking the exam. But there was one student, and I bet you throughout the 5 hours and 40 minutes, she was up and up front at least once every hour checking on the time. So when she was done, I said, do you realize that every hour when you came up and checked the clock, that was probably one question you could have answered if you hadn't come up here and looked at it. So I said, did you finish the exam? Just out of curiosity? She said, no, actually I was about 10 questions short. So I was like, we give you a warning when it gets down to 30 minutes, so that's when you should start panicking. But it's hard because you're sitting there that long and the fatigue is setting in and you've got to read carefully. So just make sure you are paying attention to that stuff. So the CPT, current procedural terminology, was developed by the American Medical Association. And again, it converts descriptions of procedures rendered by providers into 5-digit numeric codes. This allows us to communicate effectively and efficiently with the insurance carriers. It's much easier to enter a 5-digit number, 21182, rather than reconstruction of orbital walls, rims, forehead, nasoethmoid complex following intra and extracranial excision of benign tumor of the cranial bone. Example, fibrous dysplasia with multiple autografts, including obtaining grafts, total area, blah, blah, blah. Now, that whole thing that I was reading right there, that would go, if you look on page 209, look down where there's a big number 1 on the left, and then go over to where it says CPT HCPCS. That's where we'd have to write that. There's no way I can even fit one word in there. So by using a code, that's what goes in that box. And that simplifies what we are saying to the insurance companies. Majority of CPT codes are Category 1 codes. They have been approved by the American Medical Association. Category 2 codes are optional performance measures, for example, screening mammography. And Category 3 codes are temporary codes that identify new technology. So a Category 3 code, if your doctor is doing something maybe that hasn't been done in this area before, it may have a Category 3 code. Now the Category 3 codes are tricky in the sense that they do not have relative value units assigned to them. So in order for you to get paid for a Category 3 code, if you are billing one, you need to, make sure there's not a Category 1 code first, because if there is, you should be billing that. If there's not, you need to send your documentation. They need to read the documentation and see exactly what was done during that procedure. That is the only way they're going to decide how much they are going to pay you for that. Now, these Category 3 codes can stay here for 5-6 years, or they could stay there for a year and then be moved into a Category 1 status. So again, just be aware that if you are using Category 3 codes, if they are assigned a Category 1 code, you may not find it in that Category 3 next year. Again, approved by the AMA. Healthcare providers are reimbursed for the procedures and services based on what you submit on this claim form on page 209. Reporting correct code is essential because if you report incorrectly, the provider is reimbursed incorrectly, which means inappropriate claims, which can mean audits, which can mean paybacks, which can mean penalties. Your CPT coding system is used by clinics, outpatient hospital departments, ambulatory surgery, and third-party payers. It was first developed and published by the AMA in 1966. It was published up through, I believe, 1983, intermittently, before they decided in 1983 or 84 that it had to be published annually, because there were so many changes taking place that in order to keep up with the changes, it had to come out on a yearly basis, not once every 3 or 4 years. And that was done by the Centers of Medicare and Medicaid, which is CMS, the Healthcare Financing Administration, HCFA, and Healthcare Procedural Coding System, or HCPCS. So your CPT codes are level 1 codes, and for the most part, again, are professional services. Your level 2 are national codes, which are out of your HCPCS book, and those are alphanumeric codes that report services, supplies, and equipment to Medicare and Medicaid patients. HCPCS codes may be required even if a level 1 code is available. It depends on the third-party payer. And your HCPCS codes also include your drug codes. So for us, we do injections for osteoarthritis. So we give that medication which we bill for. So on our claim forms, we have to submit that to the insurance carrier. Now, this claim form on page 209, we see it as white with the gray. Where you see the black or the gray, that is typically red because it can be optimally scanned by the insurance companies. But other than that, that is the type of information, and we'll go over that as well. Again, your CPT manual is always changing, so it is updated annually. It is updated annually. It typically starts to be published around October, November, and the book starts with new codes January 1st. So I do recommend ordering your books around August, and I know that's early, but if you order them in August, we ordered ours in June, we get them as quickly the minute they come out, and that way I have time to review it, so that if there are any changes pertinent to my practice, I can not only update my super bill or my fee tickets, but I can also let the providers know. So the more time you have to review it, the better off you are. On page 210, again, they're available for purchase in November for beginning of use in January 1st. Now your CPT manual, there are symbols, so if you look at the bottom of your pages in your CPT book, you will see symbols going across the bottom of the page. In your CPT manual, a new code would be designated by a black dot, so to speak. In the CPT book that you guys have, the AMA, it may be a red dot. A triangle is placed in front of codes that indicates the description has been changed or modified since the last time it was published. Changes can be additions, deletions, or revisions of the code description. When the text has changed, you will see inverted triangles indicating the beginning and end of those text changes. you will go over the other ones, but those are the majority of the ones you'll see right off the bat. Now, if you look on the bottom of 211, there are appendixes here. These appendixes are all listed in the back of your CPT book, and mine roughly start around page 727. So they're going to start at the end of your Category 3 codes. And it starts with Appendix A. It's at the very end of the number sections. So these are reference tools. Appendix A lists all modifiers that are used to alter or modify codes. And we do a chapter just about modifiers, so we will go into detail about each one of these modifiers and how to use them. Appendix B contains a complete list of additions, deletions, and revisions to the CPT manual. So a lot of people, when they're reviewing, they will use these appendixes to see anything that changes rather than try to go through the whole book. Appendix C of your CPT manual contains clinical examples of the evaluation and management codes. So if you look at those, for example, it gives you code 99201. This is on page 749. It tells you what an example of that level office visit might be. An initial person out of town needs a prescription refill. If that happened, that's about what your doctor can bill. Your doctor's not going to do a multi-organ system review and high medical decision making for that patient. They're just renewing a prescription, so there's limited information that they need to review. Appendix D is all the add-on codes, and Appendix D is on page 774. Add-on codes are never used by themselves. They are always used in addition to other codes. So again, if you were to look at that appendix, any of those codes are add-on codes. So if you got to that code in your textbook or in your CPT book, it would have a plus symbol next to it. That tells you you can't use that by itself. Have to have something else to go with it. Appendix E on page 775 in your CPT book, or right around there. That is the complete list of modifier 51 exempt codes. So again, these would be codes where you cannot use the modifier 51. Appendix F on page 776, the summary of CPT codes that are modifier 63 exempt. So again, these are codes that cannot be used with the modifier 63 because they already state it's on an infant and you don't need the modifier to reiterate that. Appendix G, H, and I are all on page 777. And Appendix G is a summary of moderate conscious sedation. And these actually, the bullseye have been removed because there are codes for moderate sedation now. So that's been deleted. Appendix H was performance measures, and those use Category 2 codes. Appendix I was genetic testing modifiers. Those also were deleted back in 2013. On page 778, Appendix J is electrodiagnostic medicine listing for sensory, motor, and mixed nerves. So again, if you were doing nerve conduction study test, this might be a good reference tool to use with regards to what nerves or sensory nerves were being assessed. Appendix K on page 781 These are codes with a lightning bolt, and that lightning bolt is also one of the symbols across the bottom of the page that are awaiting FDA approval. So if they do get FDA approved, maybe next year, that lightning bolt will go away. But until they are FDA approved, that's what Appendix K is. Appendix L on page 782 is your vascular family. So if you are lucky enough to code cardiac catheterizations, this probably will be one of your very handy tools because it breaks down the vascular family when you code cardiac catheterizations, and you'll see when we get into it, they treat your vascular system as if it's a tree with branches. And in order to code, we need to know how far they go into the branches. And this vascular chart helps letting us know what order of the branch they got into, so to speak. Appendix M on 785. These are deleted CPT codes. So again, if you were using a code before, it will tell you it's been deleted, when it was deleted, and what the current code for it is. And here you can see, like these first couple of ones all have the letter T after them for the old deleted code. The T's are the temporary codes, so that was that new and upcoming technology. So in other words, they got assigned their level 1 code, so they're no longer the level 3 code. Appendix N, and Appendix N, you can see all the codes that change on page 791. These are resequenced codes, so they're out of order, the numeric, when you look it up. So when you look up in your book, you may see the pound symbol, and it tells you that that number is not in numeric sequence. So you kind of have to look around a little bit for where that number shows up. It's still in the book, it's just not in numeric order like it should be. They want us to do a little extra work there. Appendix O on 792. This is for multi-analytic assays. So advanced diagnostics, ovarian oncology codes. So this you may not use unless you were dealing with oncology or possibly genetic counseling, something like that. And then the last appendix is Appendix P on 797. Synchronous telemedicine services between provider and patient located at different sites. It tells you that there's a modifier required to report the interaction, and it can only be used with codes from this particular appendix with while a star placed in front of each code where the telemedicine can be reported.
Sorry.
That's okay.
If you need to go out,
Yeah.
use the elevator. I had kids walking down the
Oh, okay, sure.
So I lock the doors, but if you need to go out, just use the elevator.
Okay, perfect. Thank you.
Not a problem. Sorry.
That's okay. So again, this appendix may or may not be one you use if your provider does not do telecommunications. A lot of the providers don't bill telecommunication codes even if they do them, because a lot of them are not reimbursed. So again, some of these appendixes you will become very familiar with, others you will not. So your CPT book is composed of 6 chapters, and each of those chapters is then broken down into sections, subcategories, subheadings, and categories. So you can see, do you guys have the AMA version of the CPT book, or do you have a different version?
I have the AMA.
The AMA? Okay.
I do too.
Okay, so the first section, the evaluation and management, that section typically is the first section in your book, and it's tabbed red. Those are codes 99201 to 99499. So those are all evaluation and management codes. And you will see, again, now this is just like a brief introduction to CPT, but we are going to go through each one of these sections and chapters in great depth. The next section is anesthesia. That is a very small blue section, starting on page 53. Those are codes 00100 to 01999. We then move on to the biggest section in the book, which is green, which is the surgery section, 10021 to 69990. After the surgery section, on page 431, we have radiology, that is red, 70010 to 79999. After radiology, on page 479, we have path and lab, 80047 to 89398. And on page 579, we have the medicine section, codes 90281 to 99607. So those are the chapters or the sections that we will go into great detail on. The sections are further divided again into subsections, subheadings, categories, and subcategories. So if you looked at the size of those sections as we went through them, you know, anesthesia is like really tiny. So some people love to code anesthesia because they don't have a lot of codes to work with. You're coding the surgery section, you've got a bigger variety, there's a lot more codes, but it's broken down by body system. So even though the section looks large, you're only coding musculoskeletal, you're still only dealing with a small section of that. So again, use the in one of your exercises in your workbook, it's going to refer to section, subsection, subcategory. So I refer you back to page 215 in your textbook, and you can see down below that it tells you the section is at the top of the page, the word surgery. Subsection is the body system, so the integumentary. Subheading would be what part of the integumentary system. In this case, it's the breast. And then the category is what did we do? In this case, it was an incision. So that helps break it down when you are looking up things. And again, if you look on 216, does the exact same thing. Talks about section, subsection, and so forth. Now let's look at 216 about category guidelines or CPT guidelines. So there are also guidelines in your CPT book that provide specific information about coding in that particular section. Guidelines that are applicable to all codes in that section are found at the beginning of the section. So let's go back to the beginning of the surgery section, for example. So we'll go to page 66, which is the beginning of the green section. So at the beginning of each section in your CPT book, you will find these guidelines. So here, it tells you what is the surgical package, what is follow-up care for diagnostic procedures, what is follow-up for surgical, what is supplied materials, reporting more than one service, what is a separate procedure, which we talk about. Then it gives you unlisted procedure codes, special reports, imaging guidelines. So in your ICD-10, all of the guidelines are in the front of the book. They're not in front of each chapter. Here, they will be in the front of each chapter or each section. So your guidelines can have definitions of terms, applicable modifiers, special report information. Sometimes we'll give you clinical information. So if you look down surgery of skull base, it goes into detail and gives you a little bit more information about what that particularly means. On page 217, code format. So procedure code and service descriptions are located after the code, so which makes sense. There are two types of codes, standalone and indented. Only your standalone codes have the full description. Indented codes are listed under standalone codes. It is understood that the description for indented codes include the portion of the standalone code preceding the semicolon. So if you look down below, 26010, and it is drainage of finger abscess, simple. Now the only thing that 26011 says is complicated. What you need to do is you need to go to that base code, drainage of finger abscess, which is before the semicolon, and then add the word complicated. So if it's a simple finger abscess, you're going to use 26010. If it's a complicated finger abscess, you're going to use 26011. Always go back and read to the semicolon and then throw that indented word in there to get the full description. Does that make sense?
Oh.
Okay, because you will see lots and lots of those. So indented and stand alone. Again, the words following the semicolon can indicate alternative anatomic sites, alternative procedures, or description of the extent of the service. On page 219, modifiers. Again, we're going to go into a whole chapter with modifiers. But what modifiers do is modifiers provide additional information to the insurance company about a service that you provided. So it may mean that your doctor went above and beyond, and maybe there's some extra money involved, possibly. That 5-digit code that you put on there without the modifier does not fully describe what your provider did. So we tack on a modifier. Now your modifiers, again, are not only listed in Appendix A of your CPT book, but you also get an abbreviated version of them on the inside cover of your CPT book. Now the only thing is again, this is an abbreviated version. They can't fit the whole thing. So if this is enough for you to select your modifier, you can use your inside cover. If you want to see full descriptions, you would want to go and use your modifiers in your appendix. But again, the modifiers add information. So we have modifiers also in your HCPCS book. Now in your HCPCS book, the modifiers are associated with your fingers and toes, your eyelids. Those are also in the front cover of your CPT book, but they're also in your HCPCS book. So when you're dealing with fingers and toes, if you do a procedure on a finger, the insurance company is expecting you to put a modifier on so they know what fingers you are doing that procedure on. So let's say we do a lot of trigger fingers. People's fingers kind of get stuck, so they go and release that ligament. And some people, they've got, their 3 fingers are jammed, so to speak. So we do all 3 fingers. We use the same CPT code, but each one has a different modifier because the modifier stands for each individual finger. And that way, we get paid for all 3 fingers. If you just use the code once and didn't indicate what finger, you're only going to get paid as if you did it on 1 finger. So again, important to use those that pertain to digits. There's also modifiers for multiple procedures, co-surgeons, unrelated services, a whole bunch of things. And again, we will go over those in the modifiers section. Your CPT modifiers, so those that are in your Appendix A, are listed in descending numeric order. So if we are going to have more than 1 modifier on that CPT code, we want to make sure they're descending order. And believe it or not, the insurance companies will deny them if you put them in the other order. If you are using a HCPCS modifier, they go in ascending order. So typically your HCPCS modifiers are alphabetic. So you would start with an A modifier before you did a LT modifier for left, for example. So your numeric modifiers are descending, your alpha modifiers are ascending. On page 220, again, it talks about the modifier 22, and we'll get into more depth with those. Look down at the very bottom of this page, unlisted procedure codes. So when the AMA developed the CPT manual, they realized that they may not have hit everything that could be done in a particular section. So they designated some unlisted procedure codes for each section of your CPT book. Meaning, if you cannot find a code that fully describes what you are doing, you may use the unlisted procedure code in that category. Again, your unlisted procedure codes do not have relative values assigned to them, which means, are you going to get paid for them? Maybe, maybe not. You have to submit your documentation, and again, the insurance carrier will have somebody review that, and they will determine what they are going to pay and if they feel it qualifies as that unlisted procedure code. If they feel you should have assigned it an actual CPT code because they think it fits this better than that, then they will deny the claim and send it back to you. And you will need to, unfortunately, they will give you what code you should bill it under. You will need to do some research, dig. Don't accept that it's just denied, that they're not going to pay you. Do some research and see if you can find a CPT code that fits. If you can't, then call them and ask. And they will, again, they're not going to give it to you, but they will help guide you. But again, don't ever take a denial as, okay, I guess we have to eat that. Do some research. So in each section, as I said, with if you want to go look, for example, in the, there's none in the anesthesia section, but in the beginning of that surgery section, on page 67, we had 1, 2, and then half of a column on page 68. Those are all unlisted procedure codes. So if something my doctor did in the esophagus, I can't find a particular code for, I have 43499, which is an unlisted procedure in the esophagus. So when we do this next exercise, I'm going to pick a couple of them. You can do it one of two ways, and I don't care which way you do it, whatever is easier for you. If you knew that it was a surgery thing, you could go to the unlisted codes in the surgery section and read through them and find the ones that fit. If not, look it up the same way you would a regular procedure code, but at the very end of that column, like let's say for esophagus, you're going to see unlisted, and the code's going to be there. So you can do it either way. So if you look on page 221, look at unlisted procedure of the middle ear. So again, you can do this either way. You can alphabetically look it up, or if you feel comfortable knowing that that might be in the ear, nose, and throat chapter, you could go to that section. But if you went to ear and middle, I will show you, if I can spell, ear, middle, all the way down right before the word ear canal in your alphabetical index on page 857. So right before ear canal, you will see unlisted services and procedures, and that pertains to the ear. Does everybody see that? 69799?
Yep.
And then again, you would go to that numeric index, find that code, what did I say it was, 697, and on page 429, it says unlisted procedure, middle ear. So what if you were looking up a unlisted procedure, number 4, radiology, but an unlisted procedure for clinical brachytherapy? Knowing that it's in radiology, you could, again, go to the radiology guidelines and look at the unlisted codes that they list and pick it out that way. Or we could try to go to brachytherapy and see if we find an unlisted code. And let's go. I'm going to go both ways and make sure it comes up the same thing.
Yeah, they have an unlisted code.
And the one unlisted for brachytherapy is 77799.
Yeah.
Yep. So this one you could find both ways. Either go to the procedure, go all the way to the end and find unlisted, or go to the guidelines and find it. But again, if you are using an unlisted CPT code, it's only because you cannot find a regular CPT code that describes fully what you are doing. Category 2 codes. These are also located on the AMA website. This is a voluntary program within Medicare that paid physicians a bonus for reporting these Category 2 codes. It used to be called PQRI, which was Physician Quality Reporting Initiative. Then it became PQRS, Physician Quality Reporting System. Now I believe they're referring to it as MIPS, which I don't know what it stands for because it's just too overwhelming right now. We're trying to adjust to it. But what the system does is Medicare wants these physicians to report these quality control codes, they call them. And if at the end of a certain period, they report a certain percentage within their patient population, they will receive a bonus for that year. If they do not report these quality measures, they get dinged. So instead of getting, for example, that 2% bonus, they're going to get 2% of their entire Medicare reimbursement for that year taken back. That is going to continue to go up for every year they do not report. So if they did not report for this year, they'll get dinged 2%. If they don't implement it next year, they'll get dinged 3%. They don't implement it by 19, it jumps to 5%. Right now they're going to top it off at 5%. It will go no higher than that. But we are talking about the federal government. I suspect that will change. And it probably will go up to a higher percentage. But again, if they report it, they're going to get that 5% bonus. And again, it goes on their total Medicare reimbursement for the year. So that can add up quite a bit for each individual physician. So when you get out there, I recommend that you see if the practice that you are working in has this set up to do. Because if they don't, it may be something you want to get them on board with. Maybe they'll lose this year's incentive, but maybe you can get them on board for next year so that they get that 3% instead of getting it taken back. Medicare says that this is going to end up closing a lot of practices if they do not participate because they don't realize how much of a hit they are going to take with this. And as it is, Medicare doesn't, I mean, they reimburse fairly, but you still don't make a lot of money from Medicare. So if they're going to take more back from you, you're losing. It's not that hard to implement. It depends on the type of practice you have. So like orthopedics, we have a lot of different things that we can report with regards to osteoporosis and exercise and smoking. Primary care offices probably have a lot more that they can report. So depending on the type of practice, again, may be a good thing for you to try to set up because it will definitely help in the long run. But there's quality measures for blood pressure. For example, systolic pressure. If it's under 130, it's 3074F. 130 to 139, 3075F. Above that, 3077F in the diastolic. If the documentation indicates the blood pressure reading was 138 over 100, you document the 75F for the systolic and 80F for the diastolic. There's also modifiers that say for medical reasons it was elevated, maybe due to a drug reaction, or patient reason, maybe they denied to have it done or declined to have it done. Maybe you didn't have a blood pressure cuff, maybe it was broken. There's a modifier. That way you don't get dinged for not doing it. You didn't have the equipment to do it. So again, these measurements are considered Category 2 codes. They are in the back of your CPT book. They are after your medicine section, but before your appendix. And in my 2017 book, they start on page 681. So right around in that area. So you can always take a look through those and see what type of codes, what they have in there. There's ones for a mammogram. There's ones for artery grafts, internal mammaries, counseling for exercise programs, risk for fractures communicated to patient safety. If you told the patient nothing by mouth ordered for surgery, there's one of those. So all different types of codes. Again, the bonus is paid not only on the patients that the physicians submit quality measures on, but during that 12-month period, it is based on their total Medicare revenue. You just have to meet a certain percentage of reporting accurately. So again, if that's the case, that PQRS bonus could mean an extra $120,000 for some of these practices. Category 3 codes, again, we talked about those. Those are temporary codes. They're in there for up to 5 years. If they do not receive a Category 1 status at that time, they go away because we need to make room for more Category 3 codes. Now, just because a Category 3 code is deleted and not assigned a Category 1 code, it doesn't mean that the next year they won't come up with another Category 3 code for that. Maybe they've enhanced the procedure, or maybe in that year that it wasn't done, maybe more physicians decided that that was the wave of the future and they need to start doing that procedure. So it could reappear. But that's the instance where if that code goes away and there's no code that you can find to describe what your physician did, that's the case when you might use an unlisted procedure code as well. The Category 3 codes, again, have 5 digits, 4 numbers, and a letter. And typically it will end in a T for temporary. And again, they are at the end of this section before your appendixes. And they are found in your alphabetical index as well. So you don't have to go to a special alphabetical index for that. When you look up in your regular alphabetical index, if there is a category 3 code that is applicable to what you are looking up, you will see that code listed there with the other ones that may apply. So the category 3 codes, they are released twice a year, January and July. Now I just told you the CPT book only comes out in January. So that means if you are using category 3 codes, you do want to go out to the AMA's website in July and just print off that updated and add it to your book, just in case there are new codes there that you might need or be using. Now the special reports, these have to accompany unusual, new, seldom used, category 3 codes, the unlisted procedures. We need to send the special report, which is considered your office note or your operative note. We need to let them see what your doctor did so that they can determine how they are going to pay you. Sometimes we will need to attach the special report for a specific use of a modifier. But if you do not send the operative report with your, let's say, category 3 code, don't be surprised if it's denied. Because that's when it's denied the first time, go look. Did you send the note? If you didn't send the note, okay, now you know why it's denied. Send it back in with the documentation for it to be relooked at. Again, just as with ICD-10, with your CPT, you start with the alphabetical index, which is located at the back of your CPT manual. Again, it is arranged alphabetically, and it is a green section beginning roughly on page 799 in your CPT book. And again, by looking it up alphabetically, it will lead you to several codes that you then go look up in the tabular numeric, read the description, and find the one that fits what your provider is doing. When you see only one code stated, you still need to verify it in the tabular portion. Because what happens if the description doesn't match? I've looked at words before and mistook them for a different body part because sometimes it's close. Ilium versus, what is the other one? I can't remember. But anyway, sometimes it's one letter different and it can make a difference of what code you pick. The use of a comma between code numbers indicates presence of only those numbers displayed. So again, that means it could be either one of those codes. We have to read the description to see. If you see a hyphen, that is a range of codes. Again, we have to look up each code in that tabular section to read it fully to describe which one fits. And again, a lot of times, just like with your ICD-10, the word you think you might want to go look under, you may not find. If that's the case, find a different word. Sometimes in CPT, you can start by looking up what did you do. So, for example, hysterectomy. Other times, you can go to the body part, and then what did you do? So, again, sometimes you're not going to find it under the word you think you might find it under. You may have to dig a little bit. This is a skill, and the more you do it, the easier it gets. If you look on 226, here's some different ways you can try to look it up. So look for the service or procedure, so what did we do? Look for the anatomic site, the condition or disease, a synonym, eponym, abbreviation. Again, sometimes we may be able to find it 3 different ways, and other times we may only be able to find it 1. So, for example, if you look down under exercise 8.8, it just says that if you were looking for the service or the procedure, if we were doing a repair of a fracture of the femur, you would go to the word repair. But in this case, you could also try the word femur for the anatomic location and then repair and find it. You could go to the anatomic site would be femur, excuse me. The condition or disease would be fracture. And then in some cases, again, the synonym, eponym, or abbreviation. So don't think, oh, what word am I going to go to? Play around with it. Again, the more you get used to looking them up, I do deal with fractures all the time, and I'll tell you, fracture is my key word. Doesn't matter what I do to the fracture. I always start with the word fracture. For me, it's just easier. I typically will always find what I'm looking for rather than going to the anatomic site. Now, some people might find it easier going to the anatomic site. You will get accustomed to what is comfortable for you. So look on page 227 and look down at number 3. We have procedure. It's removal of a gallbladder calculi by means of an open procedure. Where would you start? What is the main term there for you?
Removal?
Removal. Would anybody go with something different?
Removal.
I
Gallbladder?
think this one is one you could go to either removal or gallbladder. So you guys go to removal, I'll go to gallbladder. Let's see if we can find the code for that. Removal of gallbladder calculi, open procedure.
Oh, jeez. It's a lot of removal.
There's a lot of removal.
Yeah.
See, I went to gallbladder and removal and I only got 2. So maybe it's easier to go with the body part or the anatomic site in this instance. But let's see, if you're in removal, still go see what you find. Removal of gallbladder calculi, open procedure.
I don't even see gallbladder on here.
You don't see gallbladder under removal?
No, I don't.
Okay, so what about removal of calculi instead?
Yep.
And where does that tell you to go?
See calculus removal.
Okay, so see calculus removal. So by picking the word removal, you didn't find it. Now it's leading you to calculus removal. So let's go look at calculus removal. Page 829.
Yep, it's on there.
And what does it give you for a code?
47544.
Okay, 47544. Let's go look at that code. Page 313. Removal of gallbladder calculi, open procedure. So did you find the 47544?
Yeah.
Yep.
Is that the right code?
Removal of calculi.
What's in front of that code?
A plus and a
Plus
triangle.
sign.
Okay, first of all, there's a plus sign. So that plus sign tells you that that's an add-on code. It can't be used by itself. So right there, that tells me, no, that's not the right code. And if you read the description, yes, it's removal of calculi from the gallbladder. But what's the word after gallbladder? Percutaneous. Percutaneous is through the skin. It is not open. So guess what? You're going to removal led you to then calculus removal, whereas if you had gone to gallbladder and removal, or gallbladder and, removal, go there and see where that takes you. Page 884.
We've been looking so much, I forgot what we're looking for.
Gallbladder removal
Okay,
of
removal of
calculi.
gallbladder by means of open procedure. Okay.
So under gallbladder removal, you've got calculi, right?
Yep.
So it gives you two codes. One of those codes is the one you already went to, right?
Yeah.
So let's go read the other one. 47480. Cholecystectomy or cholecystotomy, open with exploration or removal of calculus. Now, cholecystotomy or cholecystostomy is cutting into the gallbladder. Remember,
okay.
cholecyst is gallbladder.
Mhm.
So this is actually the correct code, 47480, not the 47544. So we went at it two different ways.
Mhm.
I found it much quicker, and it led me to both codes. One of the codes was the one that you guys were looking up, but the way you guys went at it, it didn't even give you the option of the open. You got
Yeah.
to percutaneous. So at that point, what you need to do is you either need to find another word to go look up, or you could read the codes around that section and find the one that says open. But typically, it's easier to just find a different word and look it up. And sometimes your going the way you did and me going the way I did is going to take us the same way. And other times, it's not. And that's why sometimes I like to do this like this, because you guys went one way, and typically I might have gone that way when I, look it up. But it doesn't lead us to the right place. So, good job. On page 228, again, there are often many ways to locate an item. The same word can serve as a main term or subterm, depending on the location. You will be locating terms throughout the CPT text. So again, begin alphabetically. Appendix B of this text will list not only the correct code answer, but also one index location for that code. So again, when you are looking up answers, I'm sure you are well aware, but in the back, Appendix B is your exercise answers, and that will actually give you the keyword that they look up first, and then what the next word was. So if you are struggling, I don't advise looking to begin with. Try a couple of different words, and if it's not getting you to where you can find the code, then go to the back, look at what that keyword is that they recommend you look up first, and try that first. So again, if you get stuck and you can't locate the index, then please, again, look at Appendix B, and they will give you the index word that they started with. You may also see the word C is a cross-reference in your CPT manual, and it leads you to another area. So again, you might go to that removal and it says C calculus removal. So we didn't find it under removal, so we're going to go to that other area that they're directing us to. But again, it works the same way as your ICD-10 book does. Alphabetically, get the numbers, and then go to your numeric listing, read the description, and then select the code. In your workbook for this chapter, just take a peek, chapter 9. Whoops, not chapter 9, chapter 8, I'm sorry. So you've just got basic questions, and then you've got the only CPT codes you're going to be looking up in your workbook are unlisted procedures. So next week, when we start getting more into the CPT book, we'll get more into the codes. Now, did I remember correctly? None of you, I don't believe, have your HCPCS books yet, correct? Okay.
I don't have HCPCS, ICD-10, or CPT.
You don't have any of the current ones?
Well, my mom gave me this to use, but I have to give them back to her sometimes. She has to use them.
Okay.
So.
Did you check with Dawn or not Dawn? I'm sorry. Did you check
Amy?
with Jamie or Amy and make sure that they ordered them?
They said they ordered them, but they're back
Okay.
ordered.
Okay. I would
So-
just follow up weekly, just so
Okay.
that they can follow up with the publisher as well. Because if it comes down to the fact that it's getting close to when you really should, I would say for the purpose of the class, obviously if you have to give them back to your mother, we want to make sure you've got some to use.
Yeah.
But you actually, until you actually sit for the exam, that's when you're actually going to need to make sure you've got them the way you want them to use. So we'll make sure to do that. Your HCPCS books, I did check, I remember, and they're not, your HCPCS books don't come out for use until January.
Mm-hmm.
So those are probably not going to be shipped until this month. It is possible you'll have them by next week. If you do not have them by next week, we are going to skip chapter 9, which is the HCPCS chapter. So we'll go skip that altogether. We'll do the chapters up ahead. And then when everybody gets their HCPCS book, we'll just step back and we'll do that one chapter. So when you get your HCPCS books, just let me know, and then we'll do that chapter. I've got my old one, but I also do not have the new 2018 one yet either. Any questions on the beginning to the CPT books?